Good evening, sir.
Hi. So you tell me when we are ready, then you are ready, we can start. So your time is exactly 30 minutes. We'll start with a case, 20 minutes of case and 10 minutes for the CVS, right?
Yes, sir.
So we can extend for 5 minutes extra if you have some like any delay or something. So maximum we'll try to finish by 35 minutes, okay?
Yes.
So we'll just go through, I'll just run through the case, then followed by I'll take your this CBS station. Okay, so this domain is basically trauma. So I'll just run through a case, then so there are six to seven vignettes. So you just read this vignette, and then I'll ask you the questions. Like the vignette one, 46-year-old gentleman. So he had a history of road traffic accident, four-wheelers versus two-wheelers collision. So patient is drowsy and restless. So when he like examined by the doctor, he was following commands and he's quite tachycardic and the peripheries are cool and the cold peripheries and blood pressure is on the lower side, 80 by 40. And on examination, he has a trauma to the right lower limb. Oh, and there is massive, extensive, you can say the bruising and swelling all over the that particular site. And there are also severe other abrasions and contusions are noted in the anterior abdominal wall, both on the left side, right side. And there is, you can say the trauma to the right lower limb with massive swelling and bruising. So this is what exactly the examination and the inspection finding by the doctor. So he is conscious, GCS you can say around 11, 12 by 15. And so in the years they have given almost 1.5 liter of fluid. So after the fluid, he shows some partial recovery in terms of like there is a slight improvement in the hemodynamic parameters. The blood pressure like has improved to 88 by you can say the 45. So now these are the different questions. So just can you tell me what are like the guiding principles for the initial management of trauma in this patient?
So this is a case of polytrauma, and like any other trauma case, A, B, C, D, E, the primary survey and the secondary survey. In primary survey, it is A, B, C, D, E, that is airway, breathing, circulation, disability, and environment. So so his GCS is 11 by 15. So in systems involved, it looks like TBI and long bone fractures and some abdominal organ injury also, with shock, hemorrhagic shock probably. Uh, and he's communicating, and still we have not cleared. Ne- Hello. Sir.
Yeah, yeah, yeah.
Yes, sir. The motor score is not given, but we need to rule out the cervical cord injury also. So
Hmm.
airway with spine management, breathing with ventilation, we need to check any thoracic injury. C is for circulation with any hemostatic uh, measures we need to take to control the bleed. And so D is disability. I mean, we need to repeatedly check his GCS, and
Okay.
hypothermia we need to prevent, because already we have given a lot of fluids. So
Okay,
uh,
so this is as per the which guidelines?
so this is ATLS.
Yeah, ATLS, like the ATLS, which survey this is like?
This is uh, so BLS survey, initial. a primary survey.
Yeah. Okay. So what are the
This is
other
primary
investigation
survey.
you will send? Okay. So what are the other surveys in ATLS? What are the other surveys mentioned in the ATLS guidelines?
Hello.
Yeah, what are the other surveys that is mentioned in the ATLS guidelines?
So the primary survey and then secondary survey. So
Okay.
primary survey is where we are dealing with the all life-threatening injuries first, and we are taking primary adjuvants along with it. If needed, like getting chest X-ray done, or maybe X-ray abdomen if we are feeling, or doing
So
E-fast.
yes.
And
So I'm coming to
uh,
that. So like I'll come to that. So what are the like the same next question is what other investigation will send immediately after this survey? The same questions.
Sir, investigations, labs, all the routine labs like CBC, RFT, LFTs, uh, and our coagulation profile, blood grouping cross matching. Um, so then we'll do basic E-fast at the bedside, looking at extended E-fast, looking at 5 points, and we'll get chest X-ray done. We'll get limb X-ray done because he's not very in a bad state. So as a primary adjunct, we can get it done to see, if possible, we can see in the Doppler whether the pulses are there. We can check pulses also. Peripherally, if pulses are palpable, we can first check pulses and look for any ischemic changes to the limb is there or. Uh,
Okay. Any other investigation?
Sir, all electrolytes, including serum calcium and
Why calcium? Why you
sorry.
want to know calcium? Why you want to like need calcium?
Sir, because there is a lethal triad of trauma, like acidosis, coagulopathy, and hypothermia that can worsen coagulopathy. And if like because he is exsanguinated, BP is still on a lower side, we might need to give him blood products, and even he might need a massive transfusion protocol also. We need to keep blood products ready. So hypocalcemia can worsen the coagulopathy if we'll transfuse blood, a lot of bloods.
Okay, so what constitute the secondary survey
Sir, the secondary
in this
survey,
patient?
sir, again, it's like in we need to do head to toe examination and look out for the missed injuries, and we need to take proper history, the ample, so previous any the even the mode of, if the relatives are available and if the patient is communicating, we can ask what has happened, what is the mechanism of injury, and
Yeah.
the previous any medical history, if he is having any medications he is on, any anticoagulants or any uh, antihypertensives,
So
and
can
any
you tell me the like the full form of ample?
uh, so ample, it is M is, so A is any allergy, uh, M is any previous medications, uh,
Hmm.
so P is so so one is the full stomach.
So what is that? What is P
AMP.
and what is L? What is E?
uh, L is
Okay. So basically, what is your the goals of resuscitation in this patient and the treatment care plan? What are your goals of resuscitation in this patient?
Sir, the goals of resuscitation will be keeping, because his age is 46, so we should keep systolic, and he has a traumatic brain injury. So we have to keep systolic blood pressure of 110 mm of Hg, Uh, we need to maintain his saturation of more than 94%. Uh, so we need to look at his perfusion parameters, like if Foley is in C2, we have inserted, then urine output, it should be 0.5 to 1 ml per kg per hour. And uh, so A, B, C, and we need to maintain normal oxygenation PO2 as well as PCO2. So we need to look at his breathing pattern. If needed, we need to support with HFNO or uh, NIV if needed for work of breathing.
So what is your differential diagnosis of shock in this patient?
Sir, there might be because in polytrauma patients we consider mostly it is hypovolemic shock considered as a hemorrhagic shock. It can be if the cervical spine is involved, then it might be neurogenic shock also. If it looks like abdominal injury, but if it's a lower upper abdominal injury, it might uh, cause rib fracture and pneumothorax and hemothorax. So uh, it can be obstructive shock also, or if any myocardial contusions. Uh, so, and it might be because of spinal shock, it might be vasodilatory shock also, spinal cord injury.
Okay, is there what is the difference between the spinal shock and neurogenic shock? What is the difference between spinal
Sorry,
shock and
sorry, sir. Neurogenic shock. For him, it is neurogenic shock. So neurogenic shock is any high cervical cord or any thoracic injury before above T6. If it is there, sympathetic chain gets also if there is a cord damage at that place, the sympathetic supply of the heart, which is T1 to T4, that is also gets compromised. And below
okay.
that level, the vasodilatation will be there, and cardiac contractility will be also less because of the sympathetic blockade. Well, in spinal shock, it will be like a flaccid paralysis and or reflexia.
Okay, got it. Okay, so what are the trimodal distribution of death? Do you know in trauma? What is trimodal
Uh,
distribution of death?
Sir, immediately on the spot, uh, if a patient like there are three stages. Fatal stage is there immediately on the spot if death occurs. Then the golden hour is the time where first is that stage. Second is the salvageable stage where we can resuscitate, and the third stage, it's complications of mostly patients succumb later on because of sepsis or septic shock.
So now this patient complain of severe pain in the left shoulder. Okay, and also like thorax, and he's remain tachypnic. Saturations are 92% with 4 liter of oxygen. There is a normal breath sounds, and there is like you can barely able to hear the heart sounds. Still, he's breathing very fast. Almost need 8 liter of oxygen. He is in severe hypotension with blood pressure of 76 by 35 in spite of almost given a 1.5 liter of fluid. There are engorged and distended neck veins. So can you analyze the ABG?
So it's pH of
So
7.25.
just read the ABG and like then I'll
So
proceed.
pH of 7.25, it is
Uh,
acidotic.
yeah.
Uh, the PSU2 is 46, so it looks respiratory acidosis. Uh, the bicarb is 20, so for acute acidosis, it's by 10, so 1. So associated metabolic acidosis is also there, base excess of -7 and lactate. So lactic metabolic acidosis with respiratory acidosis. And oxygenation looks fair.
So what do you like see here?
So there is massive pericardial effusion. Uh, it looks like hemopericardium, and There is a RA. There is a diastolic collapse of RA also. So a tamponade physiology is there. IVC is dilated.
What does the ECG shows?
So there is a electrical alterance on ultra ECG.
Okay. So what is your diagnosis?
So it looks like obstructive shock because of pericardial tamponade.
Okay. How will you proceed?
Uh, Sir, will involve uh, interventional radiology or cardiothoracic person,
Hmm.
and
Hmm.
will get it drained as early as possible with blood
Hmm.
products handy.
Hmm.
Will we need to transfuse also.
How do you like do this? What is the procedure called?
So pericardiocentesis.
How do you do this?
Sir, there is a landmark technique and then ultrasound guided technique. Subcostally,
Ultrasound or echo?
sorry, echo. 2D
Hmm.
echo. Uh,
So,
sir,
so how do you do this? Like,
Sir, with a vascular, with a cardiac probe, we generally, in subcostal view, uh, we get the maximum thickness window point, and with a needle pointing towards the left shoulder, uh, we try to enter the pericardial sphere.
so, like, how do you do? Like, it's like you have a needle, you have a set. So, like, what is this? What technique this is called?
So Seldinger's technique, by Seldinger's
Okay.
techniques only.
So, what are the anticipated complications?
Uh, so there might be uh, so if because it's a sudden accumulation, so if suddenly you will drain everything, it will reaccumulate and it will bleed further. It might damage cardiac structures also. uh,
How do you know that if the needle has like punctured the heart or needle has like
Sir, ultra under echo guidance only will be putting needle in with a 45-degree angle subcostally, and you should not like damage surrounding structures also. uh,
how do you know once suppose your needle has touched the myocardium? So how do you get an idea that during the puncture?
there should not
So,
so there should not be any arrhythmias and
hmm,
uh, any hemodynamic instability.
just read this ultrasound. So there are four ultrasound images. Just describe. So this upper one is the spleen, and lower one is the lung ultrasound. So what do you see in this patient?
Sir, in spleen uh, there is a anechoic space surrounding the spleen.
Hmm.
Looks like subcapsular hematoma.
Hmm. And what is there in the liver?
Sir, in liver there are hyperechoic areas.
Hmm.
It
What
may
does it
be
means? What
the
does this mean?
laceration, maybe laceration.
Okay. So in trauma, does it cause lacerations?
Sorry, sir. In liver.
In trauma patients, does it termed as lacerations?
No, I mean ultrasound. It is difficult to pick up. We need to do
Okay.
CT.
And the down structure, what do you see in the lungs? Lung ultrasound.
In lung ultrasound, there are it's a extensive B profile is there.
Hmm. Hmm. What do you see in the fourth image? So this image, this fourth image, last this one. What do you see here? What is that term is?
So there is shredded pleura.
What is that called?
So plural shred sign. But
Yeah, so that's suggestive of.
most of the times this shred sign indicates discontinuity of pleura, means some pneumonia or contusions.
Okay. So now this patient has a persistent hemodynamic instability. Okay. In spite of the fluid, you have drained the pericardium, then still the patient has hemodynamic instability. Okay. So the pericardiocentesis has been done, and after that you have ventilated this patient, and then still there is a persistent hemodynamic instability. So what is your next step for him?
So so we need to repeat again the blood gas if the lactates are also uptrending, and we need to look
Hmm.
at perfusion parameters also, like output. And if
Okay.
then we have already adequately resuscitated. So
Now what what will be your
we need
next
to
step?
give we
Now,
need to give blood products now, and we need to
yeah.
give reference to uh, the general surgeon also to look once.
So, okay, so before, like you have discussed, but what is your plan like in this patient with the general surgeon? What do you like think this patient should now further care plan for him? He's persistently hemodynamic instability, and we have already seen the ultrasound image,
So we
the
will check
echo
with
image.
sir. Uh, with echo image, there is abdominal organ injury with hemoperitoneum, and sir, we need to. I mean, if the patient is shiftable with hemodynamics acceptable, then we, after blood transfusion, we need to get the CT done, or maybe as a
Suppose no, suppose
damage
now this
control.
patient is not. Okay, now this patient is not susceptible to CT, but still he is persistently, you have a bedside ultrasound and you saw the images. So what will be your next care plan?
Sir, he might need exploration for as a damage control surgery, and
Okay,
with
what?
a
Okay. So you will shift him to OT with consultation with the surgeons?
yes, sir.
Okay. So now this patient was shifted to the OT. So upon exploratory laparotomy, you find that it was difficult in salvaging the spleen, and the splenectomy has been done. The spleen was extensively injured. The liver was also injured, but they have managed it conservatively. Then he was shifted to ICU with two drains and with NORAD infusion. And during this procedure, he required almost 30 units of PRBC and 6 units of FFP and 6 units of RDP. Okay. So what does this indicate? Like what scenario you are encountering here? So of course you already told that it's a massive transfusion. Okay. So
So
so what?
now maybe he's in trauma-induced coagulopathy, or maybe now it's a
Okay.
dilutional
So
coagulopathy.
how do you confirm it? Trauma-induced coagulopathy or any other things? What laboratory test you need to send?
Sir, if if you have a take facility, then we'll get
Hmm.
take done, or otherwise we'll send the coagulogram
Okay.
with PTI and repetitive fibrinogen, and
Okay.
CBC every 8 hourly will continue.
Okay. So these are the different. Can you just describe like first image, second image, third image, fourth image? Like
So
so,
in
what are the
first, R time is looks reduced, R and K time reduced, and the MA is increased, so it looks hypercoagulable. Uh, in second, the R time K time looks prolonged with MA normal, angle normal, so it looks. clotting factor deficiency, and the angle is so it's a clotting factor deficiency. In third, the MA is looks reduced. R time looks okay, and in fourth there is hyperfibrinolysis. So it's primary hyperfibrinolysis.
Okay. So now this patient remain hypotensive overnight, and then there is a decrease in the urine output, increase in the peak pressures and plateau pressures on the ventilator. On the morning round, you saw that the patient is quite tachycardic, urine output is very low, platelets counts are low, the total counts have gone up, the creatinine is high, and if you taken an X-ray, the X-ray is normal. Okay, so so basically this is the picture you see on the ventilator. You see this is the abdomen. Of course, this is taken from a net, so you are not like this is a some pseudo image, but this is the type of abdomen he has. X-ray is completely normal, and these are the ventilator parameters. Okay, I told you that there is an increase in the peak pressure and plateau pressure. So what are your differential diagnosis in this case? So with a patient of trauma with decreased urine output and the rising creatinine and of course the blood coagulation parameters are deranged.
Uh, the first will be like this is the hemorrhagic shock and
Mm.
pre-renal AKI. Uh,
Mm.
uh, After maybe he's over resuscitated, so it might be kidney congestion now, congestive nephropathy. It can be abdominal compartment syndrome, looking at the
Okay.
peak pressure, plateau pressures, and abdomen.
Okay. So like it's suppose it's the abdominal compartment syndrome. How do you proceed?
First, we need to correct all the this intra-abdominal and extra-abdominal factors, increasing intra-abdominal pressure. If available, it's better to put a intravesical catheter for monitoring intra-abdominal pressure. Then we need to make the patient sedated, paralyzed, and uh, make him negative. If needed, give diuretics, and if RT is there, we need to decompress the abdomen, and
Okay. So
uh,
now, yeah, you are all right. So now this patient is on mechanical ventilator and acidosis is worsening. So the nephrologist have planned to do a RRT for him. So, and in the meantime, your junior was putting the 12 French SD catheter, which is placed in the right internal jugular vein. And after the placement of the SD catheter, you suddenly notice that the patient oxygenation is worsening and his blood pressure further drops, and ventilator again shows a high peak and plateau pressure. There is urgent chest X-ray. So this is the X-ray.
so it looks like right massive pneumothorax with tracheal shift towards left, mediastinal
Okay.
shift,
So how to
tension
manage?
pneumothorax.
How to manage?
So we need to immediately put ICD. I mean,
Okay.
fifth intercostal space.
So how do critically debrief this incident to your ICU people, and how do you report this to your quality team?
Uh, so because definitely we have to raise the incident form, and because he's a trainee, we need to uh, first make him realize that it's a mistake, but still uh, we have to accept and justify, so that in future the same things will not happen. Uh, so with empathetic attitude towards him, but at the same time uh, we need to take measures that he should be doing all the procedures under guidance first, till the time he is good enough to uh, do procedures again for the future this thing. And we need to inform this to incident committee of our hospital, so that as a quality indicator we can do.
So we have done with the case. You just take 2-3 minutes, and then I'll be loading the CBS station, and then we'll proceed. Okay.
Yes, sir.
Can you able to see the slides now?
Yes, sir.
Just a minute. Can you start?
Yes, sir.
Yeah. So just go through the this thing. Okay. So we just will finish it quickly so that only
Yes.
10 slides, 10 minutes. Yeah. So a 45-year-old male presents with sudden onset of collapse, seizure, slow, GCS 3/15. This is the CT scan. Can you just describe the CT scan?
So this is a CT brain with Sylvian fissure and basal cistern subarachnoid hemorrhage and
Okay.
surrounding cerebral edema. Uh, there is a gross edema with sulcal and ventricular
Okay.
investment.
So basically, what is your immediate priority in the management?
So ABC, airway breathing circulation, and then uh, we have to give anti-edema measures and quickly do for the CT angio or DSA, so that to find out what is the cause of his subarachnoid hemorrhage. And
What other treatment? Yeah. What other treatment measures would you take?
so we need to keep his BP till the time the aneurysm or anything if need to secure. So keep the BP, systolic BP around 140, 150, not more than that. Hydration, adequate hydration, euvolemia. And
Okay.
uh,
This one. What are the waveforms A, B, and C?
So the A, P1, P2, P3. First is a normal ICP waveform.
Okay.
The P is the percussion, P2 is tidal, and P3 is a Oscar per,
Okay. So what does the B,
dichrotic wave.
what do you find in the B basically?
So
Abnormal B?
B is a P2 is more than
What
P1.
does,
So
what
it's a non-compliant brain. Compliance.
means non-compliant brain means raised ICP.
Raised ICP. Yes, sir.
Okay.
Compliance has reduced.
So what are the BTF guidelines for ICP measurement?
Uh, so we need to do ICP measurement when patient's GCS is less than 8, and
Hmm.
if CT is abnormal, and
Hmm.
if the CT is not abnormal, but the if any of the three is present, like age is more than 40 years, or if patient is decorticating, pupillary unequal pupils. uh,
Okay. So do you know about these Lundberg waves? What are the
yes, sir.
Lundberg waves and their types?
There
Can
are
you describe?
Lundberg's A, B, C. The C is physiological with respiratory cycle, and A is pathological. And if it in uh, so it is highest in the amplitude, around 50 to 80 of is just sometimes 100. It indicates ICP, and it can last for 2 to 20 minutes. It indicates high ICP. uh, and B is a low amplitude wave, but again, if raised ICP, it can go up, but A is life threatening.
Okay. What does this ultrasound image?
So this is the optic nerve sheath diameter, um, again to check raised ICP, and we
Okay.
measure it. It should be
Okay.
more than 5.5, then we can point 3 behind the globe.
Do you know any non-invasive ICP monitoring devices other than this?
So it's a transcranial Doppler. Uh, it measures the blood flow velocities, and uh, then even diastolic flow reversal or absent wave. There are other modalities, non-invasive, like NURS, NIRS, uh, non-invasive
Any other?
EEG uh, to get a
Okay. Any other?
generalized.
Okay.
So non-invasive,
So,
non-invasive only you are asking, or
so
invasive.
just tell me the salient points of managing raised ICP.
Sir, there are four tier approach. So first, we need to keep head in neutral position, in propped up position, make patient sedated, paralyzed immediately during the raised ICP period, keeping oxygenation, avoiding secondary brain injuries. Then anti-edema measures, if needed, we can put EVD, uh, external ventricular drain, and we can maintain uh, avoiding seizures, avoiding fever, and barbiturate coma will be the last measure, but and hypothermia.
So read this case.
A 54-year-old female who presents to the emergency department with a worsening headache, neck pain, back pain, 2 days duration. She also complains of low-grade fever and chills that developed over past 24 hours. Her son states that she seems more lethargic and has difficulty maintaining her balance. In addition, she reports 3 to 4 episodes of nausea, vomiting. She was diagnosed to have HIV positive status and was lost to follow up. Presently, not on any ART. So the
So,
pressure is ICP is looks raised. Appearance is fibrin wave formation. Proteins are high. Glucose is very low, and glucose CS
mhm.
serum ratio is 0.4. WBC is 300. Predominantly lymphocytes. So it can be looking at her HIV immunocompromised status. It can be cryptococcal meningitis, or it can be TB, tuberculous meningitis.
Okay. So how to differentiate between the two?
Sir, in both the cases, proteins will be high and sugars low and lymphopredominance. But fibrin
So,
coagulum is more with the
uh,
tuberculosis.
any specific test to differentiate between the two?
Sir, India Inc. we can do for cryptococcus and even anti-cryptococcal antigen and PCR for tuberculosis. Uh,
Can you like send also CSA biofire?
yes, sir.
Or
Yes.
yeah. What are the cause of aseptic meningitis?
Septic meningitis can be because of any bleed, which can irritate and can cause septic meningitis, or any chemical meningitis. Even when we give intrathecal colistin, it can cause. Uh,
Okay. MRI. Describe the MRI.
so there is a fracture dislocation of C4, C5 uh, with a uh, cord compression and cord edema. Uh,
How do you intubate such patients?
Uh, so we need to do manual inline immobilization, and we need to keep all the difficult airway cart ready, and without any neck movement, only with the chin lift and jaw thrust, opening the airway.
Okay.
Take all precautions.
So there are two famous guidelines described for a patient of cervical injury to rule out cervical, your instability, cervical spine instability. Can you name them?
Some guidelines.
Or you can say what are the important two important criteria, like just to evaluate patients of cervical cord injury.
So whether it is Asian
No,
Pacific,
there is, yeah,
it's
what
a
are you saying? Sorry.
nexus criteria, and
And the other one
uh,
is,
uh, so this is Canadian C spine.
okay. What is Texas criteria?
Sir, it tells you about whether patient needs invasive imaging, like CT, MRI. So, alcohol nexus. It has components like alcohol, ethanol, whether patient is under the influence of ethanol, any distracting injuries is there or not, uh, the severe mode of injury. Um,
Okay. And what is Canadian C-spine rule?
so in Canadian C spine, if again the mode of injury, and uh, if patient there is a neck tenderness, or if the patient is if uh, we see whether the patient is sitting comfortably, or can mobilize, and then we can go for head to check the head rotation, if he can rotate his head 45 degrees on either sides.
Just read this case.
23-year-old male is admitted to intensive care unit post operation following an uneventful but prolonged 10 hours neurosurgical procedure for a skull base glomus tumor. He is otherwise fit and well with no other significant past medical history and a normal baseline renal function. 8 hours later, he is increasingly oligouric despite fluid challenge, and he remained hemodynamically stable throughout the perioperative period. There has been no response to bladder washout, and a renal ultrasound scan reported as normal. His laboratory results are as follows.
Just a minute. We just skip this. Just go to this vignette. What is this?
This is intra-abdominal pressure monitoring. Uh, so this is to measure the intra-abdominal pressure.
At what level you will transduce?
Sir, at iliac crest.
What is this?
Sir, the
These two?
uh, so one is the ECMO machine. Uh,
No.
B side.
So, okay. What is this?
Uh, so this is a RPO2. So this is to measure the PbTO2.
What is that?
It is the uh, brain oxygen tension measuring.
It is brain, like this is called which monitor
partial
actually? Brain partial pressure of oxygen
partial
monitor.
pressure of oxygen.
Which monitor, this is, the name of the monitor is?
Mm.
Okay. How do we interpret this PbTO2 results? Suppose I tell you that the PbTO2, you put a probe and your PbTO2 is say 30%. So how do we interpret this 30% value? Do you know how to interpret this brain oxygen saturation?
So PbTO2 is normally it is 30 of Hg. If it is less than 20,
Hmm.
then it indicates cerebral blood flow is affected as less. So if less
Yeah,
than
but it is
20,
always in a context of something which is like compared to some other parameters and then interpreted. It is never interpreted in isolation.
so generally for this jugular venous oxygen saturation.
No. Anyway, we'll discuss that in your of debriefing session. Okay.
Okay.
I think we have come to the end. Thank you, Dr. Shraddha.
Thank,
Yeah,
thank.
we'll again, I think in the debriefing session, we'll discuss about more about all these things.
Yes, yes.
Yeah, thank you. Thank you. Yeah.
Thank you, sir.